Hello everyone, this is Archie. So today I'm going to talk about transitions of care. In this presentation, our objective is to be able to describe why care transitions are frequently suboptimal, why older adults are particularly vulnerable during transitions, and the risk factors for experience and unsafe transitions, and how to improve transition care. So here are the topics we're going to cover. So I'm going to talk about the details for each of them. So in terms of care transitions, it's defined as the movement of a patient from one set of providers' level of care or healthcare setting to another. So the other terms of the transitions, including handoff, handovers, and transfers, they can occur within hospital setting or across healthcare settings. So here's a typical flow chart for the common care transitions. So for example, if a patient has some emergency issue, patient will visit the ER, and then if a patient is stable, so will be transferred to the inpatient hospital either to schedule a surgery or transferred to the ward. And after surgery, probably will be transferred to the ICU for further monitored for a couple of days, then transferred back to the ward. And then after that, the patient probably recovered and will be discharged and sent to the nursing home or SNF for rehab. And after that, the patient probably will be discharged to home or transferred to the long-term care facilities. So all of the transitions is it's described in this flow chart. So transition care is very common and complicated. So about almost 40% of older adults experience more than two transitions within 30 days of hospital discharge. And also they sometimes they will have some post-hospital syndrome, which is a acquired transit condition of vulnerability in which older adults who have been recently hospitalized are at risk of a range of adverse health events in addition to recovering from their acute illness. So in the national study, about 22% of Medicare beneficiaries experienced care transitions of some kind each year. So half of them with single hospitalization will return to original residence, and the other half is have some complex consequences of other transitions. A few predominant transition patterns were present, which makes planning difficult. So, and also we talk about suboptimal transitions. These are very expensive. So 1 in 5 older adults discharged from the hospital is hospitalized within 30 days. 1/3 are rehospitalized within 90 days. All this need time and money. And so Medicare expects that about 15 million per year need to be paid for this suboptimal transitions. And the suboptimal transitions can result in adverse events, medication errors, inaccurate or incomplete information transfer. Almost half of all medication errors can occur during hospital admission or discharge. Inaccurate or incomplete information can result in delayed diagnosis, duplicative medical service, hospital admission, and reduced patient and provider satisfaction. Older adult is especially vulnerable. So because they have multiple problems, and also older adults need high frequency during transition, and also after they are admitted in the hospital, they probably need a longer stay there, which means that they have a higher risk to get iatrogenic complications, and also they probably will have a lot of therapeutic complex therapeutic regimens. All of this puts them on risk of one all of this will put them on risk during hospitalization. So patient, so regarding the factors for suboptimal transitions, so for example, if patient has a low education level or they have language or culture difference or no help with more than one deficit in activity of daily living, so which and also including all of the following factors can make the patient have a risk for suboptimal transitions. So regarding the system level risk factors for suboptimal transitions, it's so in the communities with a high hospital admission rate, it definitely will give patient. So the patient there will definitely have a high risk, and also it includes lack of discharge education, insufficient communication across care settings, failure in implementation of a plan for care can also put patients at risk. So for the so in order to improve transitions, some intervention or action should be considered. So intervention to improve care transitions are high priority under the Affordable Care Act, which attempts to realign financial incentives to improve care transitions and reduce hospital readmission rates. Medical legal concerns relate to inadequate care transitions, including hospital physicians who have a duty to the patient to assure care until the transition is complete. And the primary care provider has a duty to the patient to obtain hospital records if not received and endure proper follow-up once the care transition is complete. Regarding the common barriers to staff transitions, the diverse needs depending on unit, social situation, the type of transition, and also if it's lack of provider education feedback, it can also can cause a problem, and also difficult communicating with the colleagues at the previous or next site of care, and a lack of time or financial resources to address transition care issues all put the patient at risk. And these are all the barriers for patients who need safe transitions. So the components of effective transition care, including start discharge planning on the day of admission, revisit patient goals of care and advanced directives, perform comprehensive assessments of patient caregiver needs, conduct comprehensive medication review, and modify all patient medication as appropriate. Determine if other clinicians are needed to inform the care plan. Empower patients and caregivers to assert their own preference about the transfer plan. Assess patient capabilities for self-management of medical conditions, provide support as needed. Educate patients and the caregivers on the purpose of the transfer and what to expect at the next site of care. Determine which information needs to be given directly to the older adult and the caregiver. Consider health literacy and learning styles. Determine the most relevant information to communicate to the next site of care and transfer in a timely fashion. Ensure that the next site of care has received, understood, and clarified discrepancies about the care plan. Manage logistical arrangements related to the care transitions, follow up and support care after discharge, select measures for continuous quality improvement. So regarding the care transitions, there are a lot of major interventions. So here we can see that including care transitions intervention, engineered discharge, transitional care model, which all and also the next slides also include better outcome by optimizing safe transitions and the bridge model. So these 5 models are more focused on transition from hospital to home. You can see that before discharge, before transition, they have several key components, including patient-centered instructions, medication consultation, discharge planning, PCP involvement, and it's central. And after transition, they also need some follow-up home visit, phone calls, as well as a comprehensive geriatric assessment. And also it content, so the outcome, actually all of their outcome improvements, including give more benefit to patient and the primary health care providers. So another model is discharge of elderly from the emergency department, which means the patient. So this one focus on the transition from emergency to home, and also and another similar mode is geriatric emergency department innovations, transitional care nurses, and the hospital use. So basically, this model it focus on transfer patient from the ER to the home, and also has some key components before transition and after transition. And the outcome is also will give patient a lot of benefits, including decrease their rehospitalization rate and decrease their length to stay in the hospital. And the last one is a nursing home to focus on nursing home, transfer from nursing home to ED. And basically, we normally need to face a lot of patient face a problem when patient that has some issues in the nursing home. We sometimes will send them to the ED in order to rule out other significant or very bad diseases or emergency situations. So this can definitely help a patient to decrease 30-day rehospitalizations. For the policy approaches to improve transition care, CMS has placed emphasis on patient-specific goals, quality, safety, and the avoidance of cost shifting to other components of the healthcare system. And CCTB is the federal government's program to improve transition care of Medicare beneficiaries. In 2013, CMS introduced the Transition Care Management Payment Codes that allow ambulatory care providers to bill for service they perform to assist with transitions of care in the first 30 days of discharge from hospital or skilled nurse facility. Transitional care best practice in this part, the National Specialty Societies representing internal medicine, geriatric medicine, post-acute and long-term care have developed best practice framework incorporating geriatric principles across the care continuum. So the framework includes identify factors that make transition more complex, engage care receivers, and tailoring home care to meet patient needs, building recovery plans into transition care, predicting and avoiding preventable rehospitalizations, and adopting a palliative approach when appropriate that optimize patient and family goals of care. And the common SNF PCP transition care issues, including PCP doesn't realize that the patient is admitted to SNF, patient doesn't follow up, PCP doesn't receive information on care received at the SNF, and future necessary follow-up. And on return home, the patient has their questions. In a word, so all of the issues because lack of communication between PCP and the living facilities of the patient will go so, and also lack of communication between the patient and the the facilities. The best practice including identify the correct PCP, schedule follow-up PCP appointment, communicating discharge information, and ensure follow-up phone calls to the patient within 48 hours of the SNF discharge. And discharge destinations and the care venues. For this part, CMS required hospitals to provide discharge planning service for hospitalized patients. Nurse or social workers trained in development of discharge evaluations provide discharge planning service and are required to provide options for SNFs or home health service after hospital discharge. The Center for Medicare Advocacy provides the guidelines to Medicare beneficiaries for how to actively participate in discharge planning process and ensure they fully understand the options and service available. Common post-discharge setting include home with family support, home with home health care. So it works well for older adults require only intermittent skilled services. Older adults with one of these needs may also receive assistance under Medicare from OT, medical social work, or home health aides. Medicare also requires that older adults receiving home health care be homebound. Custodia care, and so this is another form of so this is another destination of the discharge. So it's including assisted living or nursing home. SNF as under Medicare, older adults in SNF must need a skilled service. So Medicare covers all or part of SNF care for up to 100 days after qualifying hospital stay for 3 days, 3 nights actually. Coverage stops earlier if treatment goals are met, while the older adult no longer demonstrates improvement. Acute rehab hospital for older adults with substantial rehab needs and considerable rehabilitation potential. Many older adults are ineligible because they cannot participate in 3 hours per day of intensive therapy. Long-term acute care for the rare patients who request prolonged hospital-level care, such as long-term mechanical ventilation, multiple IV medication, parenteral nutritional complex wound care, and inpatient hospice is the last destination patient will go. The discharge medication regimen should include an indication for each medication, stop dates, or tapering schedules as appropriate, clear behavior triggers for as needed psychiatric medications. Medication added during the hospital stay for use as needed for prophylaxis, such as analgesics, PPI, or laxatives can be tapered or discontinued. Formally reconcile with the pre-admission medication regimen. Imperative to clearly document medications that are new since admission, pre-admission medications that have been stopped, dosage of continuing medications that have been changed. Information to communicate to patients and the caregivers. So it's this in this part. So when discharge is directed to home, we should follow up appointments, warning symptoms, or signs to watch for, and also pay attention to clinical disciplines contracted to provide service in the home and reconcile medication list. When discharges to another care setting, so we should patient and the caregiver should have an idea of nature of the new institution and be able to identify of the new attending physician, and also should know the frequency of provider visits. So here are so this link is helpful tools for patients and the caregivers. Information to communicate to new clinicians. So in this one, once once the patient want to communicate to the physicians. So it includes the critical but pending study results. And oh, sorry, this one is communication from the destination of the patient will go and like living facilities to the physicians. So so they should directly communicate about the critical but pending study results, new nuances of goals of care, and the family dynamics. Otherwise, a brief prompt discharge summary should include a summary of hospital calls, list of problems, diagnosis, functional and cognitive status at baseline and at discharge, reconcile medication list, allergies, test results, follow-up appointments, goals, preference, and advanced directives, best contact information for discharge and clinician in case any question arise. So there are 3 steps to improve transitions. First, set expectations for both the sending and the receiving providers team, tailor communication strategies to the type of information being communicated and the type of transition. Target specific process of outcome for improvement using established QI methods. So here's an example of QI measures. So which include communication with the PCP before patient transfers, satisfaction of the patient, the caregiver, and the receiving clinician with the care transition. Timelines of arrival of discharge summaries, inclusion of key components in transfer summaries, ease of scheduling follow-up appointments, healthcare system use of transfer, and use of the care transitions mirror. So the summary for this topic is we have talked about the transition between across healthcare settings at risk of suboptimal care and adverse events. And also we talk about successful transitions can result in more effective improvement of care plans and reduce all of those negative effects of the transition. Optimal transition, the care contains elements of the care coordination, discharge plan, and disease of case management. The discharge medication list should be formally consulted with a pre-admission regimen. 3-step improvement transition care include set expectation, tailor communication strategies, and target specific process outcomes. So here we have question, the hospital to home care transitions, home care reduce readmission and healthcare costs. Which of the following has been shown to be a key element of successful transition program? The answer is interprofessional care coordination team. Because this one will give patient a very comprehensive assessment. It definitely help patient during transition and make the transition more successful. The first one, initial assessment within 24 hours after hospital discharge. And it's most likely happened after the transition. And this one, so, and also the third one for hospitalist transition coach transportation to post-discharge primary and special care appointments are also very important, but compared to the second one, which will give patients a more comprehensive or more better options to avoid those bad aspects of the suboptimal transitions. With question 2, an 86-year-old man is admitted to a skilled nursing facility for hospitalization for urinary tract infection complicated by delirium. His SNF stay is covered by his Medicare fee-for-service plan. Before the mission, he lived alone in the community. Staff physical and occupational therapist states that he is ready for discharge. Which of the following proves a patient discharge of a successful transition back to the community after his SNF stay? A, his baseline living situations. B, his mental status. C, the opinion of his physical and occupational therapist. D, his participation in Medicare fee-for-service plan rather than Medicare Advantage plan. So the answer is C, because physical and PT and OT are specialists, so they will give patient a very comprehensive assessment and give them their special advice. And so, uh, so definitely, if they think the patient is good to go, patient should be fine. And so whenever we admit a patient, so that's why we always put schedule TOT case manager first before we see the patient. So in the first couple of days, you're seeing admit the patient in order to let them follow up with the patient. So when we discharge the patient, uh, they will they will help. They will definitely give patients more plans in the future, including rehab and the recovery. So anyway, so whenever you admit patients, especially the older adults, we will consider contact them as soon as possible. And let's see other answers. His baseline living situation, he lives alone, definitely not a good condition for a successful transition. And his mental state, and he has delirium, which is another negative factor. His participation in Medicare fee-for-service rather than Medicare Advantage. So, based on previous experience, if patient has a Medicare Advantage, uh, so the hospitalization period will be shortened, so patient will get some benefits by using this kind of Medicare Advantage compared to the Medicare fee-for-service. So that's why we think that this FFS is not better than the MA and won't give patient any benefits during transition compared to the MA. So the best answer here is C. Okay, thank you for watching. So